The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perfusion, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP Venous cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. Easy flow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.
Such a great job on that. Hey everyone, and welcome to the part one, day one of the Corona 30 series that we're doing. And we added this in, as you all know. I think I described it in a little short ad that we had done. For people who were having difficulty getting to their meetings or whatever. So we're doing the Corona 30. It basically is 3 different parts, Monday through Friday for 3 straight weeks. Is going to include usually in the evening. It's all in the evening, and it's 3 10-credit series. So part 1, part 2, part 3. By the time it's over, you'll get 30 credits. So if you had problems, your meeting got canceled, you couldn't get there, you were sick yourself, we don't know, whatever the situation was, you're able to watch these programs and get 30 Category 1 CEU through the ABCP. And if you were having any financial difficulties, you are able to reach out to us. You'll see the contact information as we move forward. We'll put that up. But you'll be able to send us an email, let us know you're having a financial difficulty through all of this. Perhaps you were furloughed, we don't know. We're going to help you, and we're going to provide the Corona 30 series to you at no charge. So make sure you share this and all that kind of stuff. So first, let's focus on my typical housekeeping notes that I have to make. And that is, first and most important, is to thank our sponsors, LivaNova and Siemens. Both of them have been very generous with us. They've enabled us to do a lot of the things we do. And we have really appreciated their support with this. If you are on our social media, you're watching it via YouTube or Facebook or Twitter or LinkedIn, whatever it is, please like us, follow us, and share us. On YouTube, please make sure you subscribe. We need more subscribers, so please refer us to your friends. Subscribe. I cannot ask you to subscribe enough. Also, give us a thumbs up. Don't give us a thumbs down. Give us a thumbs up. As many thumbs up. Vote early, vote often. Okay, that's the key right there. And also click the bell icon for the notifications, all right? Check our website out, and there is the web address right there, contact@perfusioneducation.com. If you want to be a part of our faculty, you have some topics that you'd like to hear about, whatever it may be, and because this is the Corona 30, if you are needing any kind of financial assistance through this crisis that we just went through, your caseload 0, you don't have any money, whatever the case may be, send us an email. We've already had a couple of folks do this, and we were very happy to help them. We'll give you the 30 Category 1 CEU credits at no charge, with the understanding and the obligation that you have professionally. You have to watch the programs and participate. I mean, that's really what this is about, is learning, okay? So make sure you do that. And that's ultimately your responsibility, but it's something that I feel very strongly about, that we all need to uphold those professional ethics, okay? It's very important. We have a call-in number. You can call in and be a part of the discussion when we open the phone lines. So when you see that, the little ringing phone, that means the phone lines are open, and there's the telephone number directly in. You can be live on the air, or you can chat your question to us via YouTube, which is the one that I monitor. Magic over there is watching Twitter and the Facebook, and then he can write the questions down if there is one, or let me know, and we'll ask those questions for you, or you can call in. I'd rather you called in. We'd love for somebody to call in. We really do appreciate it. I've had that phone line for I don't know how long. Sometimes it's used a lot, but it's infrequent. And on the days it gets used, it really gets used. But I'd like you to use it. So if anybody's out there, write that number down, put it in your phone, and then all you have to do is hit call. And we'd love to answer the phone and hear from you, okay? We've had a poll, which we're going to reveal the numbers to that poll at the end of this program. Now, if you have a QR reader, you can use it right now. There it is. Just put your phone up to it, use the QR reader, or take that link and put that link in your URL address, and that will take you, and you can complete the poll while we are doing this program live. And at the end of my talk, we're going to bring the poll up and discuss what that is. I also put it on YouTube, so you can just click the link right there in YouTube, and maybe Magic copied and pasted it and put it in Facebook or whatever. So we're trying to make it as easy as we possibly can. So do it and get your poll answers in there so that we can go over those at the end of my talk today. I think, is there anything I forgot, guys? Okay, good. So let's go to my talk. And my talk is actually the same talk that I gave on Saturday, but it's a different audience now. But it basically, it says coronavirus implications for perfusion, but really this talk is about just the implications, and their implications are, I think, very broad. It's impacted us, but it's impacted a lot of people. It's impacted patients. So, you know, the number of people impacted by this, but of course I had to focus on, and narrowly focused, and I think that's what I see a lot of when I look at these reports. I see that that we look at a sliver of a segment of our society, our work society, the hospital, whatever it is, work or business, and we look at one thing and we go, look at what the impact of this was. But for every one of those, there's almost an insurmountable number of others. And sometimes what affects this one person, though it's not a direct effect on that person, though that group, it indirectly affects them, and sometimes in a much worse way than it did the direct effect. But we can discuss that, I think, as we go on. All right, so I have my clicker. We'll go to the first slide. I have no disclosures or anything, and it wouldn't be necessary in this case anyway. Okay, so we got my slides up. There we go. Okay, cool. All right, coronavirus implications for perfusion. So my experience, and I took the twist on this of what is my experience as a perfusion practice manager, a perfusion company business owner. I really don't know how to put it. I just went ahead and put it as a business owner. But this whole episode, when it first started out, created a tremendous amount of uncertainty for me. I was concerned at first, but I was really sort of anticipating what's gonna happen. I didn't know, to be honest with you. Some of me was like, well, it's not gonna be that bad here. We contained it. It's somewhere else, kind of like what SARS and MERS did. You know, and so I was sort of, I guess, planning for the worst, but really hoping for the best. But even though I was doing a lot of planning as it got worse and worse and worse, I do have to say this. I think had it gotten really, really, really bad. I mean, I'm talking Lombardy, Italy bad. At that level, where we were putting everyone on ECMO that we could, I think it wouldn't have mattered how much I planned. I don't think any system, regardless of who it was, big academic institution, big giant national perfusion company, smaller perfusion practice regionally like us, or even a smaller hospital-based program, no one could have handled it, frankly. I don't believe. Okay, but we did a lot of planning, and at some point, we activated our disaster plan. After we activated the disaster plan and we made several requirements in that, or several, things, I can't think of the word I'm looking for, we made adjustments as the CDC. I'll give you an example. We had 2 people who we knew had contact with a COVID patient. However, that contact was only the contact was only when the clinicians were in full PAPR suits. So was that a contact? And we had no guidance from the CDC at that point in time. So it was assumed they were. So those 2 people were removed from our system completely and only taking care of that one patient in that one hospital. Unless another COVID patient had been put on ECMO in that hospital, then the 2 would have had to manage each shift 2 patients. But then I was thinking, well, what's the limitation here? Well, we could use our heart-lung machines. Could we use the oxygenator out of the pump pack? Because we'd already stopped doing elective heart surgery. Elective heart surgery shut down. We'll kind of go over all of that. But again, it kind of flows back to all of this was happening, but I still had a tremendous amount of uncertainty as to where was this going to go. And I think one of the things uncertainty brings out in people is fear. And I had my fears. Now, you learn to control them, and you process them, and you manage them. But I still was fearful. What is going to happen here? I just didn't know. We did a lot of adjusting, as I said. Once CDC came out and said if the patient was intubated or you were in a PAPR suit or both, that was not considered a contact. The contact had to be specific criteria that or not. If you didn't have that criteria, you technically did not have a contact. And then reevaluating what we were doing at the time and what was happening. So there was a lot of activity that was going on, trying to figure out what is happening here, what are we going to do? Well, I understood that we had certain things that we had to do. We had to provide a high level of essential care. That couldn't go away. We had to be able to do that. We also have contractual obligations. We have contractual obligations. We also have ethical obligations. But if you're an employee of a hospital, it's not a contract in the sense I'm talking about. We as a business have a business contract with this hospital to provide people, but you still have an employment agreement. And there's rules and regulations that govern this kind of thing that you have to follow. So we're all operating under some type of contractual obligation. I had to keep all of us, the team members, myself, safe and healthy. People were scared, understandably. They didn't know how bad this disease was going to actually get. And we're in that unique position that we live in the world of being exposed to all kinds of things whenever we go into the bloodborne pathogens. We're around sick patients all the time. Hospitals are just a breeding ground for infectious diseases. So we're in the hospital all the time, but this was unique and definitely different. We had to manage different hospitals, and different hospitals enacted different policies. Some said if you had a contact, it's 2 weeks, you can't come into the hospital. Others said it was 30 days. Had you traveled out of the country or a cruise ship, there were limitations to when you could come back to work. And each one was different. There was only so many options, but each hospital was either 2 weeks or 30 days. Most were 2 weeks, however, I will say that. We had to limit the number of team members that were exposed to that patient in case it ended up. They changed the rules because I got to think about that too. Just because the rule today is X doesn't mean the rule's not going to be Y tomorrow. So I had to consider that. We had to set up lines of credit for payroll because people can't live without being paid. That was a serious issue. When you take all of the elective cases away, and when hospitals go into essentially a lockdown and not have any of their non-essential staff come in, guess who is not considered essential? Accounts payable. You can wait. So now you're confronted with that problem. So you don't have money coming in, but you still have people that need to be that need to be paid, and the manufacturers aren't going to ship things if you're behind on them. So it becomes very complicated, very stressful. There's no question about it. We evaluated the financial impact. We did that several times. In fact, we did it several times, sometimes in a day. We interacted with administrators, particularly those of smaller hospitals that may close and did. We had to find things for the team to do. As this evolved, we saw how bad it really was going to get, which wasn't nearly as bad as we had at that point been prepared for. Now we've got people who are essentially not doing anything. And I think that most of us are adults. Most of us know what we can or can't do. But you know, as an organization, I think that it was, for me, it seemed helpful. And I think we're going to have, at some point in time, some really neat pictures from people who did a variety of things. They donated blood at the blood bank because blood was definitely at a shortage. Okay, people weren't donating. They were afraid to go. They didn't want to get infected at the blood bank. People were delivering meals, people were cleaning their neighborhood streets, they were doing things. They were socially distanced, you know, because they were the only ones out there cleaning the street, but they were doing something to be productive and also getting involved in educational programs like this. Tammy, that was the direction Tammy went, and we appreciate her just tremendously. She's got great perspective on a lot of different things with your experience. We followed the news and trends very carefully. In fact, I became a news junkie. I'm not sure that that was really helpful. It's hard to say because the messaging was mixed every time I looked at something. There wasn't a lot of good coordination in terms of this is the message, one place to go, and it's unvarnished or it's not slanted, or the news was not good as far as I'm concerned. We needed, they didn't need to be doing these press releases or these press, what do they call that when they get out? Press briefings. They needed to have a coordinated message. This is what's going on. These are our recommendations. Keep them short. I think what they did was for me, in this type of business that we're in, wasn't helpful. I had to keep a positive and optimistic attitude. And that wasn't necessarily the easiest thing for me to do. But I truly do believe that people will look to their leadership, and if their leadership is negative, falling apart, not managing their stress well, you'll find that the staff typically follows that same thing. I mean, we see it in sports teams, we see it in the military, we see it, anytime there's a team The leadership really matters. In fact, I made this comment too on Saturday. If you go to a hospital, and I've done it many times, and you find a bunch of, you're in the operating room and everybody is cohesive and people get along and they're friendly with each other and they're friendly to you and helpful and genuinely appear like they're happy to be there, you can almost guarantee that the administration of that hospital, the director of that unit, supervisor, director, and then the administration of that hospital are really they foment that kind of attitude. They're themselves open and thoughtful and polite and respectful. You find that I think hands down. But when you go into a place that is malignant and everybody is trying to stab somebody in the back, including you, and they're hateful, and I don't know if you've ever seen it before in your career, I have. Sure. Almost inevitably, that's what the leadership of that facility is.
Or that's what the leadership tolerates too, if they have employees that are malignant or negative, and they don't do anything about it.
Yeah, and they will bring down everyone. That is absolutely true. That's a good point. And I did a lot of praying. So for those of you out there that know me, you know that I'm somewhat, I guess the term is agnostic. I want to believe in something bigger than us, but I'm not an organized religion kind of guy. And I think that God. So I do believe there's a God, and that He's busy. There's a lot happening all the time. So I figure if I don't pray that often, like I don't pray for everything, but when I do, He thinks, that guy Joe, he never asks me for anything. But I was asking this time, I was doing a lot of praying because we needed to get that PPP, and we had that application filled out and ready to go before it was even open. And we did, we were successful at that. But that was a lot of work to put all of that information together because it's based on your previous year's information, and every box had to be checked, every I had to be dotted, every T had to be crossed. You could not have a mistake. You can't have a comma in the wrong place. We're talking about the government, okay? So that's how they work. Okay, so let's see, go to the next slide. I'm back on my slide, thanks. There were a lot of special considerations. This was different than a natural disaster. When you have an earthquake, or you have a hurricane, or you have a tornado, it comes, it wreaks havoc, and it's gone. Of course, an earthquake, you don't know it's coming. But basically, when it's over, it's over. Hurricanes, you know they're coming. Tornadoes, you get a little bit of a warning. But they come through. Now, they can be devastating. But again, you can see it. You know it exists. It's somewhat tangible.
It has a timeline usually.
And it comes and it goes. Right. And it's not invisible. It's not submicroscopic. Okay, where you need an SEM just to see the doggone thing. This was infectious. Now, we are in medicine. Therefore, we have a special responsibility. We take an oath. And that is a very serious thing. We have a responsibility to people who cannot help themselves. But we are human and we have families that we love. So we don't want to die, albeit we put ourselves in that position willingly, but we don't want our families to die. So we go to the hospital. Well, does this mean I can never go home? What considerations do I have to make? What's the risk that I'm going to bring something like this home and infect my wife, who's then going to die, or my parents, or somebody? I mean, we just don't know. So or my spouse, I should have said, not wife. My spouse would have been more appropriate. So those are things we need to take into consideration. The team also was afraid and worried. This will have, if we had to furlough people, if we had to cut pay, if we had to go on rolling time off, or whatever it may have been, that was going to have serious financial implications for people. It doesn't matter that we're high-level professionals. people live and get paid well. I mean, I think that's a fair statement to make. But people live to their means. And we don't know where somebody, what financial obligations people have before this happened. This just may be the worst time. They might have been able to weather it 2 years ago. They might have been be able to weather it 2 years from now. But at this moment, for whatever reason, there's certain things happening that are going to really create a problem. And we also, we do a lot of auto transfusion work, and there are people within our organization who simply could not cut it. It would have been financially devastating for them, and I realize that. Staff will certainly look to leadership for direction and encouragement, and with rare exception, healthcare workers always do rise to the occasion. And so I think that that's something that I've learned through all of this is everyone, though there were considerations, there were concerns, there were worries, and there were fears, everyone in our organization, once they understood what needed to be done to protect themselves, was more than willing to do that. And there is that responsibility as well. The leadership of the organization, but of the hospitals and the director of the medical staff directors and officers, they need to make sure that the staff is safe, because if you lose the people who are there to take care of the people that are sick, and they become patients themselves, we're in a lot of trouble because there's already too few of us to begin with. Okay. So, let's see, I must have gone too far. Yeah. So, what we did once we had a known COVID case, it came very early in the process. We had a positive COVID-19 patient going on ECMO early in this disaster, before the shutdown. Okay. Simultaneous to the case was several hospitals sending out the notices that anyone that traveled out of the country could not come to their facility for 2 weeks to 30 days. That knocked out one of our people. Boom, out, gone, out of the system, because they had just come back from a cruise. We activated the disaster plan, as I said. We immediately canceled all vacations or time off. Everyone was on call until further notice. Restricted the number of people managing the COVID patient. Separated the group into teams and responsible for one hospital. So, given the total number of hospitals we had, given the total number of staff, we divided everybody up into teams and said this team at this hospital, this team at that hospital, so forth, and went around and covered all of our contractually responsible facilities to make sure that I had people who could go to that institution repeatedly. Now, the hours would have been rough because it would have been basically 12-hour shifts across the board, but such is medicine, and such is managing pandemics that may require our involvement. We eliminated any unnecessary travel to any hospitals. So as a private contract group, we have things we are responsible for to do. We didn't do those. If there is not a reason to travel to the hospital, don't go. That's just going to increase exposure risk. Made no sense whatsoever to do that. And then as the CDC was releasing more and more information, we eased our restrictions and took guidance from both the CDC and hospital regulations. We also assessed how many ECMO cases could we actually handle. And that is actually a fixed number. I can answer that question. Now, with the caveat, if you wanted to try to do ECMO with a roller pump, we could have perhaps done more than the fixed number. I did not consider that as a viable option. I think that carries with it too high a risk and would have been imprudent. That's my view, But what say you on that? I'm kind of curious what your view on that is, because that was a decision that I actually made.
I agree with you, especially if you're specific to our practice. We don't use roller head pumps for normal bypass cases. So there's a skill there that's not used very often anymore. Certainly not by our team. Now, if you were in a practice, you know, a pediatric practice or something that is accustomed to using roller pumps, I don't know, maybe they could have considered it, but I think your choice was the safest choice.
Well, my concern was that if we take a bunch of isolated roller pumps, that's a good point that you had, and that was one of the considerations. But in addition, there's no way to integrate pressure limitation, negative and positive pressure limiting, because we only have so many heart-lung machines. So you could have 4 roller pumps, but you only have one place to be able to measure pressure in 4 different systems.
Well, you could use perhaps some kind of other pressure manometer or something of that sort, you know, an old dial style or something, which I've seen on, you know, back in the day on ECMO pumps. But if you don't have the pressure, then you're certainly got some safety issues going on.
Well, given how often, and we do a fair amount of ECMO as a practice, given how often I have seen chugging in the line from even the single Avalon, from hypovolemia or whatever the case may be, just or different positioning of the patient, the amount of damage that can be done with a 6-liter roller pump when you're not right there. And if we had that many ECMOs going, there would not be somebody right there.
You'd be managing multiple bedsides.
Yes, if we got to that point. So again, my fixed number is only with centrifugal pumps. I did not go into the roller pump. I just didn't think it was a prudent decision. But then we also have the question of, I had to count up how many oxygenators do we have. That included the ECMO packs we have, and it included the number of heart packs we had. And then I had to worry about, like what happened with the earthquake in Italy. Are we going to have a problem getting them? Because if we're seeing that much, everyone's seeing that much, and just like ventilators, will there be enough?
Right.
And will there be a supply chain malfunction? So really it came down to, what do we actually have?
How long could it last?
What's available to us at the moment. And it is a fixed number. You know, so at least I know what that number is now. And it's not nearly as high as one would think. It's pretty high, but it ain't that high. Because if we'd have gotten to that point, as I said from the very beginning of this presentation, I think we would have been overrun. If we would have started just putting everybody on ECMO, we would have had 40 and 50-year-olds all dropping and needing ECMO, failing ventilatory support and needing ECMO. We would have only been able to help so many. The system would have fractured.
You can only plan for so much.
Yes, absolutely. Absolutely. And I actually consider myself a decent planner, but it could have gotten out of hand, and it could have gotten out of hand very easily. And I think I need to say that to people. I need to be aware of it. I think other people need to be aware of that too.
I think that's the same for everyone. You can only plan so much. Even the most experienced planner would have likely been overrun.
Yes.
At some point. Everybody would have been overrun at some point.
Yes.
But probably sooner rather than most people, once they put it to paper, they'd be surprised.
Listen, I was worried about heparin shortages.
Yep.
I was thinking, okay, we're going to use bivalrudin. Okay, well, how much of that do we have? Angiomax, how much of that do we have? It was starting to,
Well, because it's not just
we
one
were
thing.
really starting to worry.
It's a supply problem. And when you have a supply problem, it's not just one supply.
Right, because you can't do ECMO without anticoagulation. Not going to happen.
No.
Not going to happen. Okay. However, and thankfully, we did not have nearly as much ECMO as I had anticipated. However, ICU beds, ventilators to a lesser degree, some important medicines, because propofol was nearly impossible to find. You know, they were going to, what's that other one called? What's that stuff called? I can't remember what Precedex. Yeah, Precedex and a bunch of other things that were, of course, Versed, things like that. But toilet paper. I still don't understand what the issue with the toilet paper was. I just don't get it.
It's still kind of hit or miss if you even find it now.
What are they doing with it?
I don't know.
Yeah, it's concerning. Had ECMO been more used, this would have been a near impossibility. We would have been overwhelmed, platforms, oxygenators, and trained personnel. Once it became apparent that we were not going to be like New York or Lombardy, that was great. But by then, elective case volume was essentially non-existent. And that's when we were doing nothing. We had done 2 COVID ECMOs. Ultimately, our practice did 2 in a pretty big area, where this is not a small area.
Right.
And of course, we also covered down in Southeast, which is, again, not a small area. We just did not see it. And Matt Warhoover was on the program on Saturday. He's from Vanderbilt. They have had none.
None?
They have not put one patient on ECMO.
And they're such a busy
for COVID.
practice.
And exactly. But even our normal ECMO volume has plummeted. We had no elective hearts. We had no elective ortho, spine, anything like that. The children's hospitals were essentially stopped doing any elective cases. And I'm going to get into that a little bit, but basically it's just shut down. And people were literally doing nothing, sitting at home. And frankly, I was worried about our team, even though we're older, more professional, we sort of we're expected to process this kind of stuff. We're all still just human. And, people got involved in things. And I feel like I think that was helpful. I think that was a smart thing to do, kept people informed, stayed in communication with people, didn't just isolate myself to a bubble.
Well, and it's a stress reliever
and hopefully
to
it's
stay
helpful.
productive.
Yes.
Yeah.
Yes, it gives you a sense of worth.
Kids are home now, and there's a lot more things going on.
Yeah, and I didn't even, and I had not even thought about that from the very beginning, to be frank with you. And yes, look at, for example, Patrick and Julie. They have kids in school. They're not in school anymore.
Yeah.
If they were both perfusionists, what would they have done?
Well, Michael and I are in the same situation,
Yes.
both essential. Now, we don't have our young children all the time, but we had to figure out what would happen if, he got really busy and I got really busy.
Yes.
And what we would do.
What do you do? I know.
What do you do?
Very interesting. But I think that's where having good lines of communication with your supervision really matters.
Well, and
I
that
think
they had a plan.
Yes.
They had a plan.
And Stephanie, I think, Stephanie is our manager here in Houston, did an exquisite job. In fact, I have to compliment her. She does our advertisements. So when you see the advertisement at the beginning of the show, that's Stephanie. And y'all need to send her a little note and tell her how great that is. She hates that ad for whatever reason. I love it, but I think y'all need to send her a note and tell her how great that ad is. So what about the implications for everyone else? Well, we talked about us. We talked about all of this, but there's a whole bunch of other people. We lost her mic. There's a whole bunch of other people that have been affected by this. So when you look at the distribution of inpatient stays with and without operating room procedures, so patients that come into the hospital to have surgery or just into the hospital for some other reason, about 40%, and this is in 2014, it takes a long time for them to get these numbers available, so I don't have anything close to 2016 or 17 numbers, but I don't think it's changed a whole heck of a lot. There were 10 million plus admissions for for surgery, 25 million for non-surgery admissions. But that's 40% of all hospital admissions are for surgical procedures. That's an enormous drop when you take all elective procedures away. And what I thought was really interesting was 28.2% of that 40% of admissions 28.2% of all surgeries done are in the high risk category, 65 to 84. So the people who we are isolating are the ones who normally need surgical services, but no surgical services are available to them. And we had, look, I'll tell you about a case. 52-year-old fella didn't feel good, was having chest tightness, couldn't breathe well, ultimately developed a fever, figured he had corona, didn't want to go to the hospital, waited a couple of days, comes into the hospital. He was fast-tracked as a COVID-19, put in isolation, decompensating, taken to the operating room to put an Avalon and do VV ECMO, made the decision to do a TEE, saw a grossly depressed ejection fraction, started postulating that, well, you know, you could get acute myocarditis with this. There was all these discussions, but there was a big pericardial effusion as well. Did a window, blood pouring out of the window. Made a decision to go VA ECMO, did a sternotomy. The patient had had a giant myocardial infarction and had ruptured their right ventricle. All 3 times he was tested for COVID were negative. He ultimately did not have COVID, but he's on the VAD floor. He probably will survive, certainly needs a transplant, not going to get one anytime soon, so he's basically on a permanent VAD until, or total artificial heart, until we get through this crisis. So I have firsthand experience both with COVID patient going on ECMO and a patient that did not have COVID. Remember, I talked about the consequences of all of this are far-reaching. It goes beyond that. You know, the government officials, you know, regardless of what your politics are, and I'm not going to get into politics certainly for this show, but they talk about the depression rate, the suicide rate, the alcoholism rate, all of or alcohol abuse, substance abuse in general, all going up through this crisis. There's a lot of people that have been affected by this just as badly, not worse, not less, just as horribly as the people who contracted the disease and ultimately got very, very, very sick and may have made it or succumbed to it. Okay? A lot of people are getting it that don't even know they had it. But that's another topic for a different day, and that's going to have to be a different person giving that lecture. But there's a lot of interesting information out there about asymptomatic outcome, or being asymptomatic while harboring the infection, the virus, and never displaying any symptoms at all. Yes, asymptomatic infectors, right? Right.
Yeah.
Right. Thank you. So look here, percentage of inpatient stays that involved operating room procedures by patient characteristics. Males seem to have surgery more than females do. Again, by this, almost 63% were between 45 and 84. Again, the high at-risk group. Here, you see the most frequent all listed operating room procedures, and this was very important to me because number 4 and 5 are hip replacement, or total or partial, and PTCAs. Number 10 is fractured or dislocated hips or femurs, very common. And 14th, which is a lot lower than I thought it would be, was coronary artery bypass graft, and coming in 19th was heart valve procedures. But again, these are the patients who are going to need services that are not getting them. So during this period of time, you can do the math yourself. In 2014, there were 201,600 CABGs, 143,600 valve procedures. Add both of those together, divide it by 12, and figure out how many people who needed services could not get services during this pandemic when essentially all of it was shut down. And that's a lot of people. And if you add the 465,400 PTCAs, that's a lot of people. Not to mention the hip replacements from falling, the people that need hip replacements because they can't walk and they're in excruciating pain. What's happened to these people? Now, I know they're coming back, but had this gone on for several months,
What would we have done? What would they have done?
what would they have done? It's a very concerning question. Top 5 most frequent, all listed operating room procedures by age group. Again, we see PTCA, laminectomies, hip replacement, number 3, 4, and 5 for ages 45 to 64. For ages 65 to 84 are hip replacement, PTCA, spinal fusion, and for 85 and above, you can see again, PTCA is in there. So really it's number 3 in all 3 of those sections. And I think that's extremely important to recognize. Most costly, so this goes to hospital revenue. Number 3 through 7, hip replacement, PTCA, C-sections, coronary artery bypass, heart valve procedures, and number 9, treatment for fractured hips and femurs from falling. When you consider that 8 of the 10 highest, or 7 of 10 highest costly, which means revenue for the hospital, were essentially shut down, you have to consider what impact this has had on our hospitals. And I know they have that bailout for them with the government or assistance through the government or whatever. There's no way it can match the revenue that they lost. It may take a little bit of the sting out of it, but there's no way. There's just no way. This is going to fundamentally change, in my view, how hospitals are run for the next several years. This is going to have in my opinion, this is going to have very long-lasting impact on our overall healthcare system in this country. Okay, so we're going to look at the survey results. Perfusion needs to demand, however, these things, in my view, without exception. We need more affordable, simplified ECMO platforms. Currently, the one we use, that we're fond of, is being taken off the market, which I think is, or not taken off, they're no longer producing it, not taken off the market as if there's something wrong with it.
That sounds negative.
Yes, let me rephrase that.
Yeah.
They are, so nobody misquote me out there. They've stopped production of it for a more expensive iteration, which I think is just ridiculous.
Next generation.
It's not even the next generation. It's totally different. And I think it's a huge mistake. I think what we need are simplified systems that are more affordable, as opposed to maybe more simplified, but so much more expensive, and in my view, unnecessarily expensive. In fact, some of them that they think are more simple, I think our system is actually is simpler a word? Simpler? More simple. Whatever the word is.
More simple. Most simple.
Yeah,
it's
more simple.
Yeah.
Adoption of blended programs with ECMO specialists. I think this has to happen because perfusionists, there's just not enough of us. If this had been a huge ECMO, if this would have been needed, if ECMO would have been the only thing that would have helped these patients, given how many patients we saw, and ventilatory support was known to just not be effective,
It would have changed our profession.
there's no way we could have come. No way.
Yeah.
No way. And it would have been far less safe for the patients. If we start this now and develop blended programs with perfusion oversight, education, ECMO specialists, and significantly increase the army of people capable of managing ECMO. If we don't do that now, the next time this happens, it's not on me, it's on y'all. Because I feel very strongly about this. We also need to start adopting telemedicine. Telemedicine is here to stay. Telemonitoring is here to stay. You can have one perfusionist managing 4 or 6 patients in, or even specialists in 4 or 6 different locations with people that are trained to be able to respond to what they're asking for, and then, if necessary, call perfusionists in. But it will enhance the management of the patient, it will enhance the safety, it'll enhance the therapeutic value of ECMO by having that trained set of eyes on the monitors, on the systems, being able to look at it. You really don't physically have to be there. You can be 4 to 6 other places all at one time being able to do that. And if we ever have another pandemic, another virus, it's a respiratory virus that requires that much ECMO, and we don't have this ready to go, once again, it will be a disaster. We were on the verge of disaster this time, and we got away with it, but it could have gone the other way. So you want to throw those polls up? And we'll go over them. So I misspoke the other day. There were 48, not 148.
Of what?
But I think there's 66.
Oh.
Okay, good. So we have, okay. So we have 66 respondents, so not as many as I'd hope, but still we got 66. Let's take a look at the first question. So I work in so not surprising, 68% in a community hospital. We all know that most surgery is done in community hospitals. That's probably reflective and accurate. Okay. I practice in Washington, Harris, I assume, wait, I can't, multiple, oh, that was multiple. Indiana, Louisiana, Arkansas, Saskatchewan. Hey, up there in Saskatchewan, get hockey started again. The United States, so must be a traveler. Louisiana, Florida, Texas, Ohio, Virginia, Texas, Washington, Missouri, Georgia, Connecticut, Georgia, South Australia, Ohio, Indiana, Texas, Alberta, British Columbia, Brazil, welcome, Georgia, Illinois, Kansas, Colorado, Arizona, Montana, Texas, Missouri, Pennsylvania, Illinois, West Virginia, Canada, Georgia, now that's not the state Georgia, that's the country, Alabama, Texas, Georgia, Tbilisi, another Georgia, Ohio, Illinois, Mauritius, Ohio, Netherlands, Ohio, Texas, Missouri, California, oh my God, just scroll through that. Paris, France, Ohio, Lord, that's pretty good. That's a heck of a sampling. Geographically, that's a pretty good geographic sampling. Okay, I was excited about that. My program provides ECMO as an option. This surprises me. This actually, now these are
the higher than you thought?
Oh, much higher than I thought, yes. But that's, of course, of the respondents. So it doesn't surprise me in that regard. Had it been a bigger poll, I think there's a lot more that don't provide ECMO than do in the country. I mean, just look at where we are right now. Like, from where we are right now, I know of 1, 2, 3, 4, 5.
Are you counting hospitals
5.
in our area?
Yes, I know 50, well, close, like regionally.
Yeah.
50% of the hospitals within striking distance of this location where we currently are do not provide ECMO service. And they're full-scale hospitals that do heart surgery, so that's the criteria.
Yeah, right, that would happen.
So I find it interesting that 86% of the respondents.
Or
Yeah.
the people that might be interested in this program today.
This is true too, yes. Yeah. Oh, good point, good point. Okay, next. If applicable, our ECMO volume has 61% stayed the same, 20% increased, 19% decreased. Ours decreased. Would you agree with that, or I think it has, it's decreased.
Well, yeah, I think it has. But you know, ECMO, it's always in waves
But it's
anyway.
not. It's also not influenza season had ended. I wonder how many of those suspected influenza cases that tested negative for influenza didn't test positive for anything else before we knew what COVID was were actually COVID patients. I think it's been here longer than what we believe. I think it's been around longer than what people think. I think it was here sooner than February or March. Okay, interesting. Where I practice, our normal heart volume is between 250 and 499, 39% or 32%. Between 500 and 1,000, that's a big program, 21%. Greater than 1,000, 20%, that's a big program. Between 100 and 249, 20%. Less than 100, 8%. That's interesting, okay. Our elective open heart case volume has decreased by 44% entirely of the respondents. Greater than 50% reduction is 29%, less than 50%, 23%, not at all, 5%. That is remarkable. Where are the cases? Where did they go? What has happened to
What are those
those
patients
people?
doing?
Yes, what are they doing? Yes, did they die? Will we find out that the mortality rate during this period of time for this particular disease went way up? And is it going to end up being higher than it was for the mortality of the coronavirus?
Or are they waiting and their surgeries are going to end up being more needed than they were because they've put it off?
Yeah, but let me throw this out at you. How many times have you heard, and I don't know if this is just hyperbole or not. I don't think it is, but yeah, maybe it is. Where the patient goes in and the physician says, "It's a good thing you came in. Had you waited any longer, we would not have been able to help you." And they would have gone stage 3 to stage 4 cancer and died and been terminal. How many times? Have you ever heard that happen before?
Well, maybe not that exact wording, but the general meaning of that, sure.
Yes. You know, so what's happened to these people? You know, how many of those people are going to be harmed by this, afraid to come in? Look at the guy that happened. Look at the guy with the ruptured heart, ruptured right ventricle. Yeah. Well, I think that's very telling. If applicable, some of our perfusion team has been, nothing has changed, 62%. That's again a large percentage. 15% were repurposed. I don't know what repurposed to what. I should have asked that.
Probably a hospital institution repurposed them.
Probably.
Yeah.
14% were furloughed, and 9% were not applicable. Okay, next. If applicable, the entire perfusion was mandatory availability. 46% no, 42% yes. So we were within that. We're in that 42% group. 12% was not applicable. And last poll, I think it's the last question. No, that was it. That was the last question. Well, that was very interesting. Would have liked to have had a higher number of respondents, but that's okay. It was still good. We need to do it. We figured to learn a better way of doing it. But I love that QR code now that I know you can do that, because you have to make it simple for people. If it's simple for people, they'll vote. You think that was too long?
No, but I think they need to know it's not going to be too long.
Yes, that it's very fast. I need to put that. You know, David should have put that on the notification that it's a very easy, very short poll.
Saying that less than 2 minute poll.
Okay, so there's my talk. Do we have any comments, questions, anything you want to say? Phone lines are open. What are your thoughts?
Well, our talks, overlap quite a bit with what we're talking about, because I have a lot of questions, discussions at the end too about what we did, what we should have done, could we have done it better, what are we going to do in the future, those kind of things. So I'll save my questions for that.
Okay. Well, do you want to just go in and do yours, and then we can just have a general discussion after it's over?
Sounds good.
Okay, let's do that. Let's put Tammy's talk up.
Clicker.
And clicker.
Thank you.
And we'll go from there.
Okay. Good afternoon, everyone, or I guess it's evening. Good evening. We're glad you joined us. So my talk is kind of what we know already, kind of just a summary of coronavirus, what is, COVID-19, everything we've been hearing about nonstop for the past 6 weeks, and just kind of where do we go from here. Okay, just generally speaking, I think we've learned a lot of this already, but the corona is just from the Latin word for crown, and it has to do with the appearance of this virus under, electron microscope. There's 4 main subgroupings of the coronaviruses. They're alpha, beta, gamma, and delta. They initially identified them in the mid-1960s, and currently there's 7, including the new COVID-19, that can infect humans. So this is an image that we've all become very familiar with, and it's just what the coronavirus looks like under a microscope. All right, these are the 7 that are known to infect humans. First 4 really don't cause any major infections in non-immunocompromised people, just symptoms like common cold. And then the last 3 are the ones that are of concern. So what are the coronaviruses, generally speaking? So it's a very large family of viruses that mostly cause mild to moderate upper respiratory infections if they do infect humans. There's literally hundreds of them. Most of them just stay among animals, and anytime the virus is able to jump from a human, from an animal to a human rather, that says jump to human from animals, it's called a spillover event. So that's what's happened with COVID-19, and that's what's happened with the other 2 that were of concern in the last couple of decades. So the 3 new coronaviruses that have emerged from animal reservoirs over the past 2 decades are the ones that cause really serious illness and even death. I thought this was a great image. I found it in the Journal of Advanced Research, and it just shows that, typically it's going to be either from mammals or birds that the transmission is occurring, and you'll see any of the ones that are solid lines are known transmissions, and any of the dotted lines are supposed transmissions. And as you can see there, that the only ones known to infect humans are of the alpha or beta subcategories. And they're not saying that we can't get infected by gamma or delta, just none known yet. So that kind of goes back to what you'd said. Maybe there are, other virus infections, just like this one, that maybe we just didn't know about because maybe it wasn't serious enough. And if you're not looking for something, you certainly can't find it.
True.
Okay, just a summary of the big 3. So if you've been in medicine a little bit, or even if you've watched the news in the last couple of decades, you know about these 3. So we have the SARS, and that was, it emerged in 2002. And it caused the severe acute respiratory syndrome. That's how it got its name. So it was officially named SARS, and then CoV for coronavirus. And it emerged in China as well, and it spread to quite a number of countries within a few months. So there was a great concern about it. So a lot of people started doing some research on it. It really got the attention of the research and medical community. This one mainly traveled with people who were international travelers, and that's how it got from country to country. About 8,000 people became infected, and there was anywhere from 775 to 800 deaths is what I found on that. It became, the disease kind of disappeared after about 2004, and they linked that to tracing and isolation techniques. So I think that's why countries are trying to do what they have done with this one, because they thought maybe they can control it like they had done in 2002, but it just wasn't as effective. Then just a few years later, we had the MERS, and of course that one was named because of where it originated. It originated in the Middle East, and it had a similar type effect where respiratory distress, it was transmitted from the animal reservoir in camels and was identified in 2012, and it continues to cause outbreaks today. It's localized and can be seasonal, but it's here to stay, which is what I guess they're anticipating that might happen with COVID-19. Okay, and then we have our most recent one, which originated in China just this past year, and they are classifying it as SARS, but it's novel. It's different than the original ones, which is why it has the 2 after it. They are, it is a, it does cause acute respiratory distress similar to the original. It was declared a global pandemic by the World Health Organization in March, early March. And then as of yesterday, these are the global numbers that I could find. And you can see we're approaching the 3 million confirmed cases with almost 200,000 deaths.
That's a lot.
It's a lot.
It's a lot.
It's a lot. And you know that number is going to grow once
Yes.
we have more testing capabilities and all of that.
Yes, which will decrease its mortality percentage.
Sure.
I think it's going to end up being essentially like influenza, like H1N1, influenza A. I guess A is, which is the bad one? B? I think influenza B is the
B.
bad one. Yeah,
B.
B. It was about 0.1% or something like that.
Yeah, and will we truly ever know the numbers? Because there's going to be so many asymptomatic
No,
people.
we're not
Probably
gonna know
not.
them.
Yeah. Okay, so now that we know it's a community spread, I mean, I think we've got that out there. The mitigation strategies, and this is where we kind of need to open up the discussion. So we have a personal responsibility to, have good hygiene, wash our hands, cover our coughs and sneezes. Face coverings, that's a whole nother debate,
We're going to have it.
Yeah, are people going to start needing to do that on a regular basis, not just, during this initial phase? And how do people feel about that? Are people going to be responsible? Can governments do more than just highly suggest? Yeah. Social distancing, we're all very familiar with that now. I'm sure most communities are doing some form of this, limiting these large gather events. Most places are doing stay-at-home orders, I think, other than rural areas. Working from home, limiting outside work to essential workers only. How long can we do these sorts of things and have people survive? We have to look at the cost associated with these things as well. And then, of course, institutions and even people in their personal spaces need increased surface cleaning. Businesses, public places, your cars, your, anywhere that you think that you could spread germs. What's our responsibility to have additional techniques to help control this? All right, so these are the official CDC recommendations for healthcare facilities, which I thought was, most of us are going to be familiar with these, but I actually wasn't familiar with some of them. So I think we can discuss each of these points. So the minimizing the chances for exposure, and that was some of the early things that I think we saw in a lot of our hospitals was, they had limits where you can come in and where you can exit, just so you can limit the amount of places that people are going to be infecting. Then, then they went from there to limiting who could come in, when you could come in. Are we going to change visiting hours? Can visitors come at all? Adhering to the...
Can I add to that?
Yeah.
You don't mind the interruption?
No, I want you to.
So let me give you this interruption. So one of our team members, I'm not going to say who it is, but I'll just say that he had to take his dad to the hospital for acute belly pain. Went in through the emergency room, was told, you can't be here anymore, you need to leave. Left, ended up going home. By the time they made it home, they got the call, your parent is dead. And the impact of that on him not being there for his dad. So yeah, we can start talking about how are we gonna, how many times have we had patients who, through heroic efforts, they just aren't gonna make it. Mm-hmm. They go into multi-organ system failure and they're not gonna make it. And the families are there around the patient to be able to have that time to grieve and say goodbye. Mm. Will we lose all of these things, yeah, I get it. You know, for right now, we sort of are where we are. But we can't lose our humanity.
I agree
And
with
I'm worried
you completely.
about this. I'm really worried about this.
Right. I think all of these, especially, you know, we're talking about this is, you know, 6 weeks that we've really been doing these sorts of things, and some of them have gotten, you know, more, have become more strict as they've been trying to control the numbers, and I understand all that. But I think these are things that we really need to discuss, because if most predictions are right, this isn't going to go away, and we're, you know, likely going to have another resurgence once communities start opening.
We need a vaccine.
How long, and you know, what are the cost for all of these? And it's a terrible tragedy. And I'm sure you've heard that, you know, we've had patients of our own that they're coming in for heart surgery, no small thing.
No.
And no family there. They were
Right.
brought in through the ER, and they've been an inpatient alone.
Yes. Yes.
And I mean, I know hospitals are doing their best, and, you know, phone calls and FaceTime, and we're lucky that we have technology, but that patient was scared.
There's nothing to replace a kiss from your loved one to go into the operating room for a surgery that you know, that nothing is benign no matter what, but heart surgery is bigger than most. Sorry, but there's nothing that can replace that.
Or even on the flip side, you know, I've had 2 friends deliver babies, and, you know, it's a beautiful, happy event.
Alone.
And, well, one was able to bring 1 family member, and the other none.
None. Wow.
That's something.
Yeah, that's sad. Okay.
Yeah. Okay. And moving on down the list here. So then we have adhering to standard and transmission-based precautions. Now, this is something that we, as healthcare workers, do every day. I think it's kind of interesting that they even put that into the list there. But, you know, we have to assume that every person that we come into contact with is infectious. Not specifically for COVID, but I mean, we do that anyway, right? So we should be taking those precautions, you know, wearing our PPE. You know, maybe it's a good wake-up call for people who become laxed. You know, there is certainly protocols put into place to protect us as healthcare workers that we should be following all the time. Yeah.
We used to eat in the operating room back in the old days.
Yeah.
Have Cokes.
I've heard of people even smoking.
Yeah.
You know. Yeah.
We did that too.
Yeah. Patient placement protocols. I think all the hospitals that we have dealt with certainly had something in place, whether that be, you know, negative pressure rooms or, you know, COVID wings, suspected COVID patient areas, you know, to protect the other patients there and to limit exposure for the healthcare workers. I think many were doing similar to what we had installed, you know, plans for certain employees working in certain areas to try to limit, you know, secondary exposure. Taking precautions during all, you know, aerosol generating procedures. You know, initially it was, you know, you saw the changes. You know, first we were doing, you know, PAPR suits for everything, and then it was just, well, as long as they're intubated and they're this and, you know, these types of things, we had to start conserving because it's a supply thing,
Yep.
you know? All right, collection of samples. You know, initially it was everyone was, you wearing, you know, N95 mask for a swab sample. You have to, you know, do the full gown and all of these sorts of things for suspected patients. But of course, the more we had suspected patients, the less we had supplies, and people started becoming worried that we weren't going to have enough. So CDC changed that to collection of samples as long as you had traditional PPE and it was not during an aerosol.
bronch.
Yeah, exactly. Any kind of procedure that would be, you know, aerosol, then that was fine. Then, you know, managing the visitor access and movement within the facility. So that initially started with minimizing chances for exposure, and then moved to many places no visitors at all. limited visitation to no visitors at all. And then, of course, we had movement within the facility. If you weren't supposed to be at the facility for an essential purpose, whether it be, administrative types or even clinical people, you shouldn't be in the ICU if you're not there taking care of a patient.
No social rounds.
Absolutely not. And even limiting the amount of, our team often, we might have someone working in the operating room and someone working in the ICU of the same hospital. Check on your teammates.
Help each other.
Yeah, we're not going to do that anymore, because if that patient's in the ICU, or even if they're not taking care of a COVID patient, you're supposed to limit that, because you could be that asymptomatic carrier, right?
Absolutely.
Yeah. Implement engineering controls. This has to do with we've seen this a lot in some of the retail stores that are still open, putting up screens, any kind of barrier that you could help prevent the droplets, and also asking people to wear masks as soon as they're, at the hospitals, which I don't think is a bad thing. All right, monitoring healthcare workers. So I think we've all seen this, where we're being screened as we come in. We're having our temperature taken. We're being asked if we've had any symptoms. And generally speaking, if you are a healthcare worker, I would hope that you are monitoring your temperature even when you're not at work, Yeah. Training healthcare workers. Many healthcare workers are very trained and understand, of course, about disease transmission, but there's many that aren't, or maybe not as well versed. We've got nurse assistants, we've got janitorial staff, and all of those
Transportation,
food supply and delivery. All of those people were recommended to have special training so that they could really understand the precautions that they needed to take to protect themselves. And thankfully,
and others from them.
Absolutely. And thankfully, I saw a lot of changes in the hospitals that we work in, So and that even goes to removing food from, COVID positive patients that maybe aren't on a ventilator. Maybe they're just in the hospital. We have to be careful with all of the things we're taking out of the room. Having dedicated stethoscopes and other kinds of equipment, and making sure that those get special care for being disinfected once they are removed, especially on those face shields that they were wanting everyone to wear. There's a limited amount of those. Most hospitals don't have enough for every single person to have one who was dealing with a COVID positive or possible COVID positive patient. Yeah. That goes right into the environmental infection control. We're doing more disinfecting, not just of the equipment, but of the rooms, of the hallways, of the bathrooms, all of those sorts of things.
I'm going to say this. I remember, if I can.
Sure.
I remember a time when you could take a person and blindfold them and take away their auditory senses as well, and put them in a car and drive them someplace, get them out, and bring them into a hospital. They had no idea they were in a hospital. They couldn't see, they couldn't hear, but you could smell the cleanliness. You knew you were in a hospital just by the smell. I have been to hospitals, none here where we are now, but in a previous place where I lived and worked. There were so many flies around the waste area, where the environmental, the biological waste would go. It was so filthy that if you did that same experiment, from the minute you walked in the hospital, and they prettied it up, they made the entrance look beautiful, but you could smell how disgustingly filthy it was. And I remember going back even farther, a hospital in New Orleans that was run by the Daughters of Charity, Hotel Dieu Hospital was the name of it. It's called University Hospital now. It's with I think it's LSU. But if you were walking down the street or down the hallway and you passed a piece of trash like a wrapper, and a nun was behind you.
And you didn't pick it up?
And yes.
Yeah.
They were going to give you a tongue lashing, and you were going to pick that up. Now, they didn't mean it in a mean way. It was a teaching moment, but those were their expectations. We need to get back to that.
Yeah, and I absolutely agree with you. How many times have you seen someone step over that piece of trash?
A lot. More than I can count.
Now, and I'm having trouble now with when I see a piece of trash and I don't have any gloves, you know, out in the world.
Yes.
I'm hesitant to pick it up because I don't really know, like, you know, you're a little, is it worth it? Do I not? But normally, that's a thing that bothers
Before
me.
all of this.
Before all of this.
You just pick it up, put it in the trash.
Yeah, especially.
And think nothing of it.
Right. And, you know, going back to this thinking of this environmental infection control, this is something that's bothered me for a long time, is, you know, we all want quick room turnover. We got another case, we got a surgeon who's got, you know, cases all day. How quick is too quick? Because I know we've been in rooms where, you know, everyone's on them to get it done. I'm not putting the blame on, you know, people who are turning the rooms over, but sometimes you see things that are missed, and if you see the things that are missed, imagine what you don't see.
Yep, agreed, 100%.
Yeah.
Agree with you
So,
100%.
Yeah, okay.
Yeah, we need to start cleanliness. How does that saying go? Cleanliness is next to godliness, isn't it the way that they say?
I mean, especially in a hospital environment, you would think that would be our number one thing, because what's the big thing that everybody gets tracked on are patient infections, secondary infections.
Absolutely.
You know?
Absolutely.
Okay, and then lastly, the communication protocols between facilities and health officials. Making sure that different hospital systems, surgery centers, wherever, when they have those positive cases, that they're sharing it with health officials and other hospitals in their area so that everybody can kind of assess what's going on.
It is time for us to put competitiveness aside. I think in the sake during the era of this latest pandemic. No question about it.
Absolutely. Okay. I think we covered those pretty well. All right, so what are our expectations of what's going to happen? Well, I think we're already starting to see that locally. We've had some new things happening today. You know, communities are going to be lifting some of these restrictions in phases. We're seeing that here in Texas as of today. We're going to have increased testing capabilities, which of course is going to lead to increased overall cases.
All healthcare work. Anyone working in healthcare needs to be tested.
Absolutely.
Because I can almost guarantee you that there are, I just can't wait to see what the numbers are.
I think it's going to be shocking.
I think it is too.
Yeah. And then, are we expecting a second wave of infections? I think we are. But I also think that, you know, there's ways to continue moving forward, not regressing back to where we are, and still have a responsible techniques to manage them. Okay? All right, so here's where we get to have some real discussions, some questions that I thought were important. Did we over-respond? What do you think, Joe?
It depends on in what context do you mean.
Well, I mean, in all contexts. Now, I'm not really talking about planning. I think you can never plan too much for the unknown.
You mean, did we respond by shutting the country down? Over-respond? Is that what you're referring to? Like, stop all elective cases?
Yeah.
I think that the answer to that, for me, I think I can answer that yes and no. Yes and no. I think when we didn't know what this was, no, I don't think we ever responded. I think once we recognized what it was and what it wasn't, then I think we did overreact.
Well, and what do you think about? I know we've talked about this off air, I think, but why didn't we happen like New York?
That's another very good question.
I mean, specifically us, because we're in a big, big city area.
Well, even Miami. I mean,
Yeah.
Miami, we had San Francisco, Los Angeles. I mean, they had a few pockets here or there, but nothing like New York. Nothing like New York. And it's a really good question, and I really don't know the answer to it. I don't know. It's going to be interesting to see. My first thought was that the virus in San Francisco, because of course we don't know how many cases they really had in China.
Right.
So was it they really didn't have that many cases, and that the virus in San Francisco or Washington State in that West Coast was somehow different, that it had mutated enough by the time it got to Italy and then New York that they're not the same virus. I mean, I think they would have told us that by now.
You would think.
But they haven't.
Yeah.
And that could be because they don't know. I don't know.
Yeah.
But it is odd to me that New York fell apart the way they did.
Yeah.
But not everyone,
No.
because it was more the public hospitals.
Well, you know what
I
I was
think
thinking? What about New York is lots of big cities use mass transit, but they really rely on it
They
there.
do.
And
They
I
do.
wonder if that was just a real place for community spread. You're very close together. You know, subways, they're probably not cleaned very often. I don't know.
Well, I mean, I don't know either. I can't answer the question yet because I just simply don't know. But I think that that New York, I don't think has a higher African American population, which seems to disproportionately have more problems than do others. I think they were 58% of all the deaths were African American, but yet they only constitute 13% of the nation's population. So that's troubling when you look at that.
Yeah.
They disproportionately have sickle cell anemia. There are things that are, racially disproportionately higher in depending on whether you're African American, whether you're Asian, whatever it may be. So I don't know. It's a really good question, but I don't know if that was the issue. If the fact that they had nursing homes with infected patients and that spread like wildfire. Was it governmental mismanagement? Was it just a different virus mutation? All of those things I don't know the answers to, but I think we need to know the answers to those things, because there was a completely different experience here in Houston, in Nashville, in San Francisco, even in Chicago and Detroit, which got an uptick, but it didn't get nearly to the level, again, that New York did. And Miami, the Jacksonville, Florida, Tampa, these are not small cities.
Right.
It should have been much worse than it was if it had been anywhere close to the same percentage numbers that we saw in New York.
So do you think that has to do with New York was in the beginning and other places were more prepared?
I don't know. I can't answer the questions. I just don't know.
All right. What about herd immunity? You and I have talked about this before.
England tried to do it.
Didn't work, huh?
No, it went pretty poorly.
Yeah.
It went pretty bad.
Yeah. I think if we protect the immunocompromised and the people who are most at risk, that might have been a way we could go.
Yes, they let it rip.
Yeah, they just said, eh.
Well,
Yeah.
I don't think they quite went it might not have been I think it was more, we're going to
Everyone's-
make this as a conscious decision.
Right, and everyone's
then
going to
they had
get
to pull
it.
it back.
And yeah.
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 I meant, like, we're all going to get it anyway. So, yeah. Okay, and then what about the economic impact versus protecting human life? Now, of course, we want to protect human life any way we can. That's not
Sure.
what I mean at all.
But economic impact impacts human life.
It does, especially the very disproportionately to certain class groups.
Yes.
And they're going to suffer for a long time.
Yes.
I mean, I think we're all thinking about this a little bit, but it hadn't even occurred to me that people who aren't working, children.
Could you open the phone line? Sorry.
People who aren't working, children who aren't going to school, that rely on those meals. They don't have the protection.
Oh, I know, and that's sad too.
Yeah,
But
and I think
that's going to become a real interesting discussion. That there are kids in this country that have to rely on school for to get a meal. I mean, there's some things that
it's just things we did. I mean,
that really concern me.
Who would have thought that a pandemic would affect all of these things? Not just the sick.
Yeah.
Not just people being out of work. There's just such a big trickle-down effect.
Yes, absolutely.
Yeah.
And a health effect.
Yes.
Because if you're not eating, it's affecting your life. If you're not going to the doctor for various things, typical illnesses that are easily managed, it affects your life. If you are now unemployed where you were and you can't take care of your family and you start drinking or abusing drugs or become desperate and start stealing or whatever it may be.
Whatever it may be.
What about elderly people who have no one to take care of them?
Yeah.
I mean, so societally, this has been, in my view, a disaster.
And what should we do about schools? I mean, I think a lot of decisions have been made for this school year, but what are we going to do about the fall? If there is a resurgence, are we going to cancel schools again?
Well, I think fear about, how sick will these kids get? And then, of course, schools, we know that they, it's how you get the German measles and everything else. That's how you get it, right?
Right.
Going to school. So, and flu and everything else, colds, I mean, they're all doing that.
Well,
but
not just the health
I don't know
aspect,
that,
but what about the parents and taking care of their kids? This can't be a permanent solution.
No, but I don't know that they should have closed the schools. I think they didn't. Once they knew kids were likely not going to, they would have been vectors, but I think you could have managed that.
Yeah.
I think we should have. I don't think we should have closed the schools.
What will we do and what should we do for this second wave? Assuming it's going to come.
Yeah, I think if it does, I don't think it's going to be, I think it'll be more blunted. I think this is going to be like H1N1. I remember H1N1 was so crazy. We had so many patients on ECMO.
Everywhere.
Massive amounts of ECMO. Do you remember those years?
Yeah.
Remember that? I was calling you all the time.
Yep.
Remember?
Yep.
It was crazy. And the respiratory, the ARDS rate was huge. And our systems at times were very, very, very stretched. Really struggled a lot. But we got through it and we're fine. And that was a highly infectious disease as well. I don't know that it's less infectious than this is.
Yeah.
I don't know. I don't know that that's true. It's a virus. It's easily transmittable with respiratory droplets. If you touch a surface where it was and then touch your eye, you're probably going to get it. Yes, we had a vaccine, but we didn't have a vaccine at the time.
Right.
The influenza, the H1N1 was unique, and you really didn't have good immunity. Then they came out with Tamiflu, which was very helpful for it. So a treatment like that we need.
We need something like that.
There's real debate about the hydroxychloroquine and whether that really does work or not. There's debate about it with or without the azithromycin.
Well, I think people are panicking to try to figure out something quickly now, and time. We're going to need time before we know what is a real applicable treatment, if there one even exists right now.
Absolutely.
Yeah. And any other thoughts?
No, I don't have too many other thoughts other than I think that novel respiratory viruses are going to occur. I think they're going to continue to occur. Cross-species transmission is going to happen again. I'm doing a talk, I think it's tomorrow, on passive antibody treatment.
Yeah, I think that is tomorrow.
The convalescent plasma. And I learned such so many interesting things. I've never been as interested in this. I'm looking, by the way, in case anybody out there or anybody knows of an incredibly talented virologist. I've been searching for one, trying to find one that I could cajole or trick into coming to the studio and getting on the program. But I've never really had so much interest in viruses as I do now. And they're fascinating.
They're fascinating
things. They're not alive because they don't meet the definition of being alive.
Because they don't have cells. But
that and they can't replicate without a host.
Right.
But they're sort of like little mini machines. But
there's a whole debate in the scientific community as to whether or not to change the definition of what is alive based on viruses.
Yes.
Yeah.
It's really fascinating.
It is.
So, I think it'll be, and where did they come from? Were they the first cells and we evolved from that, becoming more complex, from RNA to DNA and double helixes and becoming more, cells becoming more complex? Was it somewhere in the middle? Was it two different paths? Do they have an alien origin? I mean, and when I say alien, I don't mean alien beings that came here. I mean space stuff that came to the United States. Are y'all laughing at me over there? First contact. But, that's how most of the stuff that's on this planet got here, right? From impacts and becoming, a different thing. So I think it's fascinating. I've been reading a lot about it. And but the therapeutic plasma, tomorrow's program is going to be really interesting because I've learned some really, really neat things about that. And of course, they're using it now. It may sound like it's new. I'll give you a preview. I'm only going to say I'll say it, even though it's programmed tomorrow. Do you know how long therapeutic plasma has been being used in the U.S. or in the world, but specifically in the U.S.?
No.
Take a wild guess. How many years? Take a wild
25.
guess. 25, yeah. Try again.
100.
Try again.
200.
No. 130. 130 years.
Wow.
130 years.
How come we don't hear about it more?
That's one of my questions for tomorrow. Is if it's been around that long, how could it not? Why are we're doing it again for this, and it may be a good idea, but
that'd be great.
If it was that good of an idea, there's been a lot of opportunity over the years. But when you don't have a vaccine or an appropriate treatment for it, it's kind of like it's all we got.
Yeah, use what you can.
Use what you can.
Yeah.
But I can't say that I'm that excited about convalescent plasma as the end-all, be-all of managing COVID-19 infection. I think it's going to come and go like it has for years. 130 of them.
All right. Well, that's everything I got.
That's everything you got. Okay.
Yeah, thank you. And
thank
we'd
you.
love to hear from anybody in the audience on your thoughts
Yes.
about these things.
Do we have anything on FaceTime or the other thing? Twitter? No? Well, you know what we're going to do? This is Corona 30.
All right.
This is extra. Look, we put these 30 programs together like really quickly because we wanted to help our audience who needs CE Fact Out. I'm sitting here doing the program, getting a text from a good friend of mine, Joe, desperately need CEUs. It's him. There was another person that works even with our group who needed these credits. So we did this Corona 30 because we want to help y'all. We want to do this for our colleagues, put it together, be provocative, have some good discussion, some good information that we're transmitting to you, being productive, and hopefully you're able to watch it and get the education. Increase you're certainly going to increase your brain just by listening to us, okay? There's no question about that, all right? I mean, no, seriously, Tammy and Joe, the Tammy and Joe show. It's great. So we'll see you tomorrow. We're going to go ahead and end early. Do your evaluation. so that you can get your course credit, your certificate. Make sure you have an account, free account in Perfusion Education and .com, perfusioneducation.com, and you go to the library. You make sure you sign up. It's free to do that. You get the Corona 30. If you need the financial assistance, call us. If you don't, put it in your cart. Pay for it. It's very affordable. And you've got 30 credits that you can get in the next 3 weeks, conveniently from your home in the evenings for an hour or two,
Monday
through Friday. And we don't even tie up your weekends. So we appreciate everyone. Thank you for coming and joining us today. We will see you tomorrow, same time, same channel. See you later.
Good night.
Mixed Cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perfusion, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP Venous cannula and the EasyFlow Duo. For arterial, direct, and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOT device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the epoch that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the epoch device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.